The following podcast is part of a certified educational activity titled Catalysts for Change in Gastric and Gastroesophageal Junction Cancer, Digesting New Evidence and Future Directions of Care with Innovative Immunotherapy and Targeted Platforms. Access the entire activity and complete the post-test at peerview.com/VTE860. Downloadable slides and practice aids are also available.
Thank you for coming to this information CME topic, Catalysts for Change in Gastric and GE Junction Cancer, Digesting New Evidence and Future Directions of Care with Innovative Immunotherapy and Targeted Platforms. It's really quite timely because the landscape for treatment for upper GI cancers has really changed dramatically. So tonight's panelists, my name is Manish Shah. I'm upper GI medical oncologist in New York. We have to my left Marcus Müller. He is a GI oncologist in Mainz, Germany, and Professor Ronan Kelly. He is an upper GI oncologist currently in Texas at Baylor, right?
Yeah.
Yeah. And these are esteemed colleagues. I've known them for years. They actually have led practice-changing studies. I'm still trying to get mine, so hopefully that'll happen soon. And our goals for today, to enhance your understanding of the latest clinical evidence and guideline recommendations supporting the use of immunotherapy and targeted platforms for patients with gastric and GE junction cancer. We'd also like to provide you with the tools needed to help you formulate personalized treatment plans for patients with gastric and GE junction cancer. And then we'd like to share strategies for applying a team-based approach to monitor, mitigate, and manage adverse events associated with modern systemic therapies. Our topic again is promoting equity and revitalized care, collaborative strategies to address gaps and challenges in gastric and GE junction cancers. And just by way of background, there are persistent gaps in care. So we have in the first line setting data from 2011 to 2018. This is the Flatiron Data Network, I believe. About 3,300 patients with advanced gastric cancer, and of those, 25% of patients did not receive treatment after diagnosis. And of the patients that received treatment, only half of those received second line, and less than a fifth received third line. So this reflects, I think, both a gap in our management, but also it's a comment on the burden of the disease and how sick these patients are with gastric and GE junction cancer. We really want to put our best foot forward for treatment, and that's really a key aspect. The next row is the Flatiron Health disease, and here it was very similar data. No first-line therapy in 24% of patients, and 76% received chemotherapy-based treatment only, so they didn't receive a targeted agent. And of course, currently we know that we have access to trastuzumab in the first-line setting. We have access to checkpoint inhibition in the first-line setting. That should cover more than 2/3 of our patients. And ultimately, because these patients are sick, and because most of these patients are not treated at academic centers that specialize in upper GI cancer, at least in North America, we really do have significant gaps. So in terms of addressing gaps, here are some really key aspects. So previously, first-line chemotherapy resulted in a disease progression and death within a year for most patients. But now with anti-PD-1 therapy, both nivolumab and pembrolizumab, most patients are able to live more than a year. That's really a pretty important benchmark. Nivolumab and chemotherapy is approved in the first-line setting, irrespective of PD-L1 status. Recently, pembrolizumab plus chemotherapy was approved for the same indication, irrespective of PD-L1 status. For HER2-positive disease, pembro plus trastuzumab plus chemo is used for CPS 1 or greater. Nivolumab is approved in Asia, irrespective of PD-L1 status, in the third line or greater setting. Pembro was approved in a third line or greater setting, but that approval was withdrawn by ODAC and the FDA. And then, of course, pembrolizumab is approved for TMB, tumor mutation burden 10 or higher in the United States, and for MSI-high tumors. Of course, these tumors, we know about that from colon cancer as well. MSI-high tumors are really very sensitive to checkpoint inhibition. And here is a schematic of, on the left, we have the immune landscape for how we think about cancer. And it's, let's start at the tumor. So the tumor lives in a microenvironment that has pro and anti-inflammatory cells. And the treatments that we have, chemotherapy, radiotherapy, can modify the immune microenvironment as well as targeted therapy. The T cells get educated in lymph nodes, and so the lymph nodes are very important, and they're, interferon gamma signatures or GM-CSF. This is for macrophages. This is important from a standpoint of presentation of antigens. And then you have activation and priming of the T cells in the lymphocytes. That's mediated by IL-2 and IL-12. And then you have cytokines that can hone in the peripheral T cells into the tumor. So this cycle affords lots of opportunities for drug development. Right now, we're really focused on PD-1 inhibition here at the tumor microenvironment, but there's a whole array of things that can happen with the immune system. And then here on the right, we have a schematic of Claudin 18.2, which is a gap junction protein. As tumors develop, they lose their polarity and they lose this gap junction, and they expose Claudin 18.2, allowing that to be a target for drugs like zolbetuximab. And then also FGFR2 is another new target that we're going to be talking about. We'd like to really thank Hope for Stomach Cancer support system. This is really, really important. They provide patient education. They provide information to patients who are actively getting treated for stomach cancer. Again, in the United States, 80% of patients are treated in the community setting where physicians may not see a lot of stomach cancer. So this kind of education and programming is really critical for patient care. And so we'll begin our program both with Dr. Marcus Mueller and Dr. Kelly. And this will be really informative in terms of setting clear standards, first in the metastatic setting and then in the localized setting. So advances in first-line immunotherapy for metastatic gastric and GE junction, Dr. Mueller.
Good evening, everybody. Thank you very much for the kind invitation, Manish and PeerView team. It's my pleasure to be with you, and I'd like to present you the advantages of the new combination of immunotherapy with chemotherapy, particularly in the metastatic setting. And that we can go easily into the situation, I would like to present the case. William, aged 64 years, with metastatic GI junction adenocarcinoma. After mild dysphagia for 5 months and 5 kilogram weight loss, he went to his family practitioner, got the endoscopy, and there was a mass, malign mass at the junction. The biopsy showed poorly differentiated gastric adenocarcinoma, and the CT scan showed 2 liver lesions, a large lymph node mass around the stomach, and the thickened junction. And of course, if you see this patient, you can also question yourself, is this still oligometastatic disease? I mean, we have been discussing with the new results whether we can really move the field forward, not only for treating the patients all the time with chemotherapy, but also thinking about additional options. Now, And here you see our European perspective, but this is very similar to the NCCN guidelines. Here you see the immunotherapeutic options in metastatic and advanced non-resectable gastric and junction cancers. In the perioperative setting, we have the more or less the approval for the FLOT regimen, which is classical perioperative chemotherapy before and after surgery. Then we have, of course, the cross protocol, also now with the approval of adjuvant nivolumab, and particularly for squamous cancers, but also for high adenocarcinomas in the esophagus, we can use definitive chemoradiation with cisplatin and 5-FU. For first line, we do have nowadays 2 approvals for IO plus chemotherapy, either nivolumab or pembrolizumab. At least in the US, you have the approval for all comers. For us in Europe, we have the approvals for CPS 5 or higher, for chemo plus nivo, and for pembrolizumab. We do have also now the approval for CPS 1 or higher, and for the esophageal cancers for CPS 10 or higher. I think this is a very important message. We know that if the patients have higher CPS levels, they respond better to chemotherapy plus immunotherapy. In second line, of course, we have the FOLFIRI regimen, very often used in Europe. And I know you also use taxanes and irinotecan. And for squamous cancers, we have also the approval for nivolumab in the squamous cancers. Unfortunately, we do not have second-line approvals for immunotherapy, at least I think in Europe and also for you in the US. Now, what about the trials we have seen most recently? And I would really highlight that particularly the Keynote 811 is the combination of chemotherapy, targeted therapy against HER2, and immunotherapy. And this will be the future. So far, for HER2 negatives, we have 2 randomized phase 3 trials clearly showing that the combination of chemo and IO improves not only the overall survival, but also PFS and overall survival. And the Checkmate 649 has been published already 3 times, and we have already the 4-year survival. The Keynote 859 has been presented as well, and we will see follow-up. And at ASCO this year, we already saw the 3-year survival follow-up. As you see here, all the studies used the chemotherapy in a first-line metastatic disease setting. Responses were, of course, higher in the Keynote 811, as you see here, with 73% versus 58% for CPS 1 or higher, and with in the classical chemo plus IO with nivolumab, 60% versus 45% with chemotherapy alone, and 52% for pembrolizumab plus chemo versus 42%. And the hazard ratios have been clearly significant. More than 30% of our patients benefited. As you see here, the hazard ratio for PFS 0.7, 0.68, and 0.72. And the overall survival improvement was 4.3 months for the Keynote study. The Checkmate 649 improved for 3.3 months, but you should know that at the end of the Kaplan-Meier curves, there is a clear change, and we have long-term survivors nowadays. Now, with the next slides, I'd like to show you the Checkmate 649 I have been working with. And this was originally a 3-arm trial. Nivolumab plus ipilimumab did not show a good benefit for the patients. Therefore, we will focus on nivo plus chemo versus chemotherapy alone. It consisted of Xelox or Folfox, which is standard of care everywhere, more or less worldwide. This was the largest trial ever done with more than 2,000 patients. 60% were CPS positive. And here you see the results already, the overall survival in all randomized patients versus the patients with PD-L1 CPS 5 or higher. And I highlight really the 4-year survival is 17%. That has never been seen before. And I think this is a clear signal that the patient benefit from chemo and IO. As you see here, the median was 14.4 versus 11.1, but I think the Kaplan-Meier curve separated early, and they stayed separately, very similarly to the all randomized. Also, you see here nicely from 8 to 13% in all randomized, also a benefit for long-term survivorship. And also, with regard to the quality of life, there was also an increase of quality of life for these patients. So there is a clinically meaningful improvement of overall survival with longer follow-up, and also particularly for patients with PD-L1 CPS5 or higher. Now, with regard to the subgroups, I'd like to show that more or less all patients benefited here, irrespective of region, ECOG performance status, primary tumor location, signet ring cell carcinomas, liver metastases, or MSI. Of course, MSI patients even more benefited from the combination with chemo and IO. Now, what about the PD-L1 expression? And as I said, you see here, with regard to overall survival, the hazard ratios clearly improve if the patients have more CPS levels up to CPS 10 or higher, hazard ratio becomes excellent. And you see also that CPS lower than 1, lower than 5, and lower than 10 did not very much provide a clear benefit with regard to hazard ratio. So the high CPS levels bring the benefit also to the lower CPS levels. With regard to overall survival, however, you do not see this difference. Overall, the response rates with nivolumab were always better, up to 60% versus 40 or 45% in this regard. Now, what about the long-term survivorship? And the colleagues also tested here specific curves looking into the landmark analysis, particularly patients with complete remission or partial remission more than 80%, but also early response show an excellent 5 and 6 year survivorship. As you see here, in around 60% patients survive if they have early responses. I think this is really very important to see our patients benefit if they respond early. This is also shown for chemotherapy alone, but not that strong as you see nicely here. Now, with regard to the tumor control and better quality of life, I would like to discuss with you the dose escalation and the maintenance, since oxaliplatin cannot be given all the time due to the neurotoxicity. And with the Optimox trial in colon cancer, we also have similar results. You could stop the FOLFOX or oxaliplatin, continue with IO, and then if the patients have progressive disease, you can reintroduce chemotherapy and IO, and then treat again until more or less progression at reintroduction, and then you go for second line. I think in that regard, you can improve quality of life if you reduce chemotherapy and keep the patients on maintenance. Now, what about the MSI status? You see nicely here, patients with MSI really benefited very well with a median overall survival of 38 months versus 12 months with chemotherapy alone. Clearly highly significant. Therefore, please look into MSI in your patients. Now, what about CPS5 or higher with regard to responses? Again, clear signal, early separation of the curves, and higher response rates were maintained, and responses remaining after longer follow-up as well. Now, with regard to our quality of life in the trial, we've been happy to publish this in the JCO. You see nicely for the overall total score, but also for the gastric cancer subscale, you see that the patients with nivo and chemo benefited at least more, even if chemo also alone improved quality of life over the baseline in black here. So again, the benefit in quality of life was clearly significant for this trial. Now, then I would like to come to Keynote 859. This is a very similar trial. Again, the PD-L1 status was tested with the immunohistochemistry score 22C3 antibody, and patients were also randomized in 2 arms. This was done with cisplatin 5FU or CAPOX versus placebo. Primary endpoint was overall survival. This was recently presented at ESMO 2023 last year. And as you see here, also the Kaplan-Meier curves are very similar to the 649, placebo-controlled. And you see here, again, after 1 year, benefited improvement, particularly after 2 years, a clear improvement of 10 months, 10%, and also for the PFS, a clear signal that the Kaplan-Meier curves separate. Overall responses improved around 10% with pembrolizumab compared to chemotherapy alone. Now, what are the typical side effects? And since I treated in the trials more than 40% of more than 40 patients, I saw some patients with hypothyroidism, but also 1 patient with hypophysitis, and this patient was really deteriorated with his general situation. But then we couldn't believe it, since the CT scan clearly showed a tumor reduction, and then we tested for the hormones, and we gave the patient corticosteroids, and he benefited very much, and he is still nowadays in full remission. Now, therefore, please think about hypophysitis or the other side effects, hypothyroidism, in these patients, as it can occur, particularly after around 2 to 3 months.
So let's go back to the case. So remember, we have William. He's a 64-year-old gentleman, 5 months of dysphagia, 5 kilograms weight loss. He had an endoscopy that showed a GE junction cancer, biopsy confirmed adenocarcinoma with signet ring cells. He had 2 liver lesions and a large gastrohepatic nodal mass. His tumor was HER2 negative, IHC 0. PD-L1 was CPS 7. He was microsatellite stable, TMB5. KRAS showed amplification, and he had a p53 mutation, and there was no other contraindication for checkpoint inhibitor therapy. So let me ask you, we'll go to Dr. Ronan. What treatment options might you consider in this patient?
Oh, well, I think here, the data would show that a PD-1 inhibitor plus chemotherapy would be and that would be universal. I think there's no, we have got a bit of controversy between the Europeans and the Americans here. Interestingly, I will say that the FDA are going to try to regulate this. They're trying to put their hands around, for all the people in the audience, what the optimal CPS is. As you know, initially we were doing TPS when we designed these studies, and then we figured out that it's really not PD-L1 at the membrane that's important, it's the CPS. But in Europe, they agree with CPS greater than 5. Here, we definitely have an all-comers indication. So I think I've been a nivolumab guy because I was involved with 649, so that would kind of be my main one here, FOLFOX plus nivolumab.
So Marcus, how would you also were a 649 guy, but how would you pick nivolumab versus pembrolizumab? Is there anything about this dosing or the schedule? Are these guys interchangeable?
More or less, I agree with Ronan. The benefit of nivolumab is that you can give it in 2 weeks weekly or in 4 weeks schedule. Pembrolizumab can give in a 3 weeks schedule or in a 6 weeks regimen. And particularly in patients, when you give FOLFOX every 2 weeks, nivolumab is easy to give, and then the patients don't have to come one time more than if they are on pembrolizumab, they have to come a little bit more often to the doctors.
Yeah. What do you find with the Q6-week dose of pembrolizumab? Do you find that the higher dose, does that affect toxicity or tolerance?
at least what we see in colon cancer, yes, I think the 6 weeks regimen has a little bit more side effects. However, if the patient particularly is in some kind of maintenance, then of course the 6 weeks regimen is better.
Is preferable. And then, Ronan, in terms of organ dysfunction, so, we know about, some autoimmunity like inflammatory bowel disease or something like that, but, someone with liver mets, maybe they might have already grade 2 or grade, high LFTs. Does that, make you pause with regard to immunotherapy?
That probably will. I mean, obviously there's certain cutoffs that you'd be nervous, but the ones that I'm nervous about are the patients with autoimmune disease, certainly those inflammatory bowel disease patients, because I've had patients, probably like everyone, that have developed colitis, and you bring them into the hospital, it's really hard to control it. And what happens when they don't respond to steroids? So I haven't been overly worried about LFTs unless, they're crazy high.
Right.
But I'm certainly worried about those patients, say, with multiple sclerosis or those patients with inflammatory bowel disease.
Right, exactly. So there's pretty much unanimity that chemotherapy plus a checkpoint inhibitor in someone with a CPS of 7 and no other contraindications would be, that would be the treatment of choice here. It's interesting. So people get, next generation sequencing panels, which are really, really important. We know that the patient has microsatellite stable disease. You'll get other information that may not be important, like KRAS amplification, not so critically important for upper GI cancers. P53 mutation, more than half of upper GI cancers will have a mutation. It doesn't really have a role in terms of treatment planning or anything like that. But, that's, I think, part of the challenge as oncologists is that we have to piece through all the data and, identify what's the relevant information.
I had the honor to present the Rational 305 just last year at ASCO GI, and this is the third checkpoint inhibitor which will have the approval very soon in gastric and junction cancers. And the study was also very similar to 649 and the pembrolizumab studies. As you see here, tislelizumab with 200 milligram every 3 weeks was combined with Xelox or cisplatin 5-FU and versus placebo with chemotherapy alone. The eligibility criteria were also very similar, and in all these trials, HER2 negative patients were only included. Overall survival was the primary endpoint, particularly for the PD-L1 positives. You should know that they used the so-called TAP score, and in that trial, we will also discuss very shortly the role between the TAP score, the CPS, and TPS. However, as you see here, the CPS is more or less very similar to the TAP score. Here you see on the left side, you see the immune cells which can be PD-L1 positive, and the tumor cells PD-L1 positive. So if we measure the tumor cells and the immune cells together, this is so-called the CPS score, and we count the cells. The TPS score is measuring PD-L1 only in the tumor cells. And the TAP score, should be easier for the pathologists in the future because it is just a visual estimation what kind of cells and in an area, in a tumor area, are positive. And this is, again, the tumor cells and the immune cells together. So far, the Rational 305 improved very similar to the other Nivo and Pembro studies, improved the overall survival, as you see here on the left side, the overall survival was 17 months in median versus 12.6 months for placebo. And you also see that the Kaplan-Meier curves separate, particularly after 2 years, very nicely with 24 versus 38 months for the patients. Now, with regard to PFS, again, you see and the end of the Kaplan-Meier curve, you see that there is a nice improvement in PFS for many of the patients, particularly after 12, 18, and 24 months. Now, with regard to the final analysis, which was done in February this year. And you see that, again, with the ITT population and the PDL1 score of 5% and more, particularly the patients with PDL1 score of 5%, benefited more than the patients in all comers. However, I think the signal is clearly significant, clinically meaningful, and in the future you can then decide whether you take pembrolizumab, nivolumab, or tislelizumab. Now, with regard to progression-free survival and tumor response, again, similar data. The PFS improved from 6.2 to 6.9, but again, you should see that the end of the Kaplan-Meier curve shows a benefit, and with regard to tumor responses, again, improvement from 40 to nearly 50%. With regard to safety, there was no new safety signal. Also if you compare tislelizumab with nivo and pembrolizumab. Therefore, I think it's also important to mention the ongoing trials. You see here not all ongoing trials. There is a huge amount of ongoing trials. However, I would like to mention particularly the LEAP trial, which is running in the US, which combines pembrolizumab, lenvatinib, TKI plus chemotherapy, and the initial safety results were quite positive, and the first also preliminary anti-tumor activity observed was 73%, disease control rate 93%. With a compassion of 15, another checkpoint inhibitor plus chemotherapy is underway, and also overall survival in the phase 3 looks good, and the trial will be important for the future. Then we do have the EDGE and the STAR trial. I don't want to go into all these details, but as you see here, the idea is now to combine different IO drugs together with chemotherapy to improve the overall survival even more. Thank you very much. Yes, as a summary, chemoimmunotherapeutic concepts in PD-L1 positive patients are well established through many phase 3 trials, at least the 3 I showed, but there are even more from the Asian studies, also phase 3 studies, and the PD-L1 treatment is accepted as a global standard of care. We have novel concepts targeting together checkpoint inhibition and HER2, for example, in the 811 trial, and there will be more underway. And deep understanding of the tumor biology, such as CPS, is relevant particularly for the next large phase 3 studies.
Terrific. Thank you so much, Marcus. The next topic so we talked about first-line metastatic and the role of immunotherapy in the advanced setting. But actually, there have been very important practice-changing studies in the localized or non-metastatic setting, and Dr. Kelly will take us through that.
So like what we did in the metastatic setting, we just introduced Catherine, who's a 65-year-old lady with resectable GE junction adenocarcinoma, good performance status. And you can see here she elects to use immunotherapy in combination with surgery. So just have a think about these for your own practice, your day-to-day practice. What therapeutic options are you aware of for a lady who has an operable GE junction cancer? Would you consider a neoadjuvant approach? Would you consider an adjuvant approach with immunotherapy now? Would it be chemoradiation or would it be chemo alone? And what factors help you decide your decisions? So why is immunotherapy important in the surgical setting? Well, I had the privilege of leading this large study called Checkmate 577, and I'll show you some of the thoughts that went into that. But we designed a study where we could give adjuvant immunotherapy after chemoradiation and surgery. And we specifically did that because we were very concerned that the dose of chemotherapy, the so-called cross regimen, uses very low dose chemo. And so we've known about that for years, but the idea was if you use radiation sensitizing doses, does there a synergy there with the radiation? Does it maximize cell kill? But we've been worried about the systemic disease. We've been worried about, when you look at the relapses, they tend to be more in the distal area rather than locally. So we'll talk about Checkmate 577. Certainly in the US, our radiation oncologists working with our medical oncologists, the preferred regimen up to this point has been has been CROSS. And in Europe, I think FLOT has really been a preferred regimen. And now today, as a result of that data, do we see a change? I have some issues with the study. Maybe we can talk about those. But this was what was presented today, the ACPE trial. And it was a study that was done in Germany, who are really experts at giving FLOT. It's where FLOT originated. And they saw that there was much higher overall survival in that particular group compared to the CROSS regimen. But again, we'll talk, I think, about some of the issues with the study. There was certainly some challenges. I think they're not used to giving radiation clearly in Germany, because it's normally a very well-tolerated regimen, but not in Germany for some reason. So let's see. So we're going to talk about Checkmate 577 as one of the studies. And then there's been a couple of other ones with chemotherapy alone. And we're still waiting. I don't have all the trials that Dr. Moeller showed, because we're still waiting on some of these to read out. But what should we do for patients who don't achieve a PAT-CR following chemoradiation? So that's always been a challenge. And that's why we designed Checkmate 577, because we knew we couldn't just watch those patients. I think you all, throughout your careers, you know those patients recur very quickly if we don't give something else. But the challenge has been they're typically frail, because removing the esophagus is one of the largest oncologic operations we have. And so patients it takes them months to recover from that. So we designed the study with adjuvant immunotherapy in mind. But before we did that, some people asked me, well, why were you thinking on this? This was some preclinical data that I had shown when we were designing Checkmate 577. We were able to show, so we had this animal model at Hopkins and in Allegheny Health Network, and we basically performed surgery on these rats. We took the jejunum and we bypassed and anastomosed it onto the distal end of the esophagus. So we basically bypassed the stomach. As a result of that, all the rats get this very large amount of acid and bile fluxing onto the distal part of the esophagus. So we almost hyperstimulate what happens in a human. It's not perfect, but it's the closest we have. So all the rats get esophageal cancer after about 6 months. So then we started giving radiation to those animals. And you can see here, we were looking at some of the checkpoints that some of you are familiar with. They all went up post-radiation. You can see LAG3, GITR, OX40, etc. When we looked at PD-L1, we could see that it also goes up if you look at the far right. Now, we only gave one dose of radiation. It was 16 gray of radiation to the animals. We could see there was this immediate increase. Now, it's very interesting. In Checkmate 577, which was in humans, we almost saw the exact replica as we had predicted in the animals years ago. And I'll explain that. But it goes up, but then there was a transient decrease. So the million-dollar question everyone is always asking is, does radiation alter the immune microenvironment, which then makes subsequent immune checkpoint inhibitors better? It's hard to prove it, but we've seen now in the lung cancer area, those of you that treat lung have seen the PACIFIC data where chemorads followed by durvalumab seems to really help. And if you start the durva quickly, there's a much better benefit. And then today at the plenary session, we saw the Adriatic study in small cell lung cancer, the exact same thing. If you could start the durvalumab in small cell quickly after radiation, there was a benefit. So that was our thinking coming in to Checkmate 577. So this was the study. It was all patients. This was a global study. It was done really all over the world. So it wasn't. I sometimes worry about single country studies. Not that there's anything wrong with that, but I think when we have a global perspective, it gives us a better sense. Is this really, what can change practice across the world? So this was really a global study. You could see anyone with stage 2 to 3 esophagogastric disease. Now, we included squamous cell and adenocarcinoma. Today in the ACPE study, they did not look at squamous cell. We know squamous is much more sensitive to radiation. And then we gave chemorads and surgery, and anyone who had a pathologic complete response we didn't include in the study because we knew that those patients did well over the years. So we just said, well, let's take the worst biology. Let's take those that haven't had a PAT-CR. and then we gave them adjuvant nivolumab or placebo, which was the standard of care, because after chemoradiation surgery, we were watching these people carefully. So you could see here it was done in 27 countries. So it really wasn't one country dominating the whole space. And you could see what we showed was a doubling in the median disease-free survival. Now, the primary endpoint was disease-free survival. We don't have overall survival yet. Everyone asks me, when are you getting overall survival? I would say probably next year, but we'll have to watch this space. But the primary endpoint was disease-free survival. There's going to be challenges in interpreting overall survival because people will have gotten immune checkpoint inhibitors later in their cycle, so that makes it a bit more difficult to interpret. But here you'll see the hazard ratio on the initial follow-up at 24 months was 0.69, and then we were seeing directionally improved hazard ratio with some longer follow-up, and this is the last cutoff we have, which was at 32 months. It went to 0.67. So really a very positive study. If you look at distant metastasis-free survival, which again is not overall survival, but it's the time between randomization and first distant metastasis appearing. Again, if you look at the right, which was the earlier cut point, the hazard ratio was 0.74. Then as time went on, it directionally improved 0.71. You could see the placebo, the median distant metastasis-free survival was 16 months versus 29 months with the addition of nivolumab. Now, this is what the FDA, I think, is really going to try to get their heads around. And I'm sure all of you guys are really confused with all the different assays that we have to assess PD-L1. Probably the most famous is the 22C3 assay there that you'll see under pembrolizumab. So that one is used a lot, and then the 28-8 assay. But you'll see some of the other ones there, and there's a little bit of confusion amongst all of us in terms of which is the optimal one. As it looks like 28-8 and 22C3, there's good concordance between them, but I think most of your pathologists are probably using those particular assays. And then Professor Moeller showed you the difference between TPS and CPS. I'll tell you, when we originally reported Checkmate 577 in the New England Journal, we reported the TPS, which was what we thought was important at the time. But then our reviewers asked us, well, will you look at the CPS? And so we did that post hoc analysis. It's the same as in metastatic disease. I don't think we should be checking tumor membrane expression. We need to understand what the immune cells are doing around the tumor, even in these early stage diseases. So we have a couple of other studies. Some of you may be familiar with these, some of you may not. So I'm going to show you 3 of these. They're all doing the same thing. So if you move away from, say if you drop radiation, certainly in a gastric paradigm, we don't use radiation. We've always, remember the old days, we liked magic, we were perioperative chemotherapy. FLOT is certainly the mainstay now for a gastric cancer, operable gastric cancer. So the question is, could we add an immune checkpoint inhibitor to FLOT or to chemotherapy to improve perioperative chemo? So that's what they did in Keynote 585. This was a randomized phase 3 trial, and you could see here the entry criteria on the left. They were localized gastric or GE junction adenocarcinomas, no prior treatment, able for surgery, and then they looked at PD-L1 assessment. They were randomized in a one-to-one manner to either chemotherapy, and originally when the study was designed, FLOT wasn't the mainstay. So you could see here they had cisplatin and capecitabine, or cis and 5-FU, but there was a subgroup later that had FLOT, and then or the addition of pembro, which is given every 3 weeks, and that was for 3 cycles before surgery and then 3 after. So that's sandwich approach, and then maintenance pembrolizumab for up to 11 cycles. So did that help? You'll see the primary endpoint was pathologic complete response, and then there was also event-free survival, and then overall survival. There was key secondary endpoints listed there. So we've seen this data, and let's have a look at it. The PAT-CR looked like it was better. And if you look at the main cohort here, look at this, 2% PAT-CR with chemo alone. Now, today's data on ESOPEC did not show 2%, much higher. So again, did today's data overperform or did this study underperform? It's hard to do, cross-trial comparisons, but just keep it in the back of your mind. But you can see with the addition of pembrolizumab, the PAT-CR rate went up to just about 13%. So there was about an 11% difference delta there. And then if you look at the subgroup which contained FLOT, so it went from 2.4 to 13%. So again, similar. So there was no major difference with using FLOT or just Cis5FU in this particular study. And the event-free survival is there, and the overall survival is there. Unfortunately, this was not a positive study. I think the hazard ratio there for overall survival is 0.90. You can see the lines are almost superimposable. So we did not see a benefit of adding atezolizumab to perioperative chemotherapy in this global trial. This was really disappointing. I'm hoping when we start teasing it out about PD-L1 cutoffs, I'm hoping there may be some ctDNA assessed that we can find subgroups that are responding. But the main study was not positive. There's another study. So that was Keynote 585. This is all perioperative chemo. This one is the exact same design. You'll see, but now they're changing the PD-1 or PD-L1 instead of atezolizumab or pembrolizumab. This is durvalumab with FLOT. And you could see here they were giving 2 cycles before surgery and then a number of cycles afterwards. And again, PD-L1 expression was a stratification factor. It's a large study with 900 patients. So we don't have all the data. We just have some of the pathologic complete response. But again, I'd urge you just to look at the FLOT PAT-CR rate. Here. In the last one, it was 2 to 3%. Here, it was 7%. Today, we saw much higher levels. So the Durva did improve it here. You could see there was a 12% delta with the addition of durvalumab plus FLOT versus FLOT alone. And then the investigator assessment was 13%. We don't have any more data on this. I'm hoping this translates into event-free survival and overall survival, but we're waiting on the data. And then this is just when you add in those major pathologic responses that we keep hearing about, those patients that almost had a complete response but not quite, so that the definition here of a near complete response is single or rare groups of cancer cells at the time of resection. And again, you'll see a delta here of about 12%, went from 14 to 27. So in terms of PAT-CR, it looks like the addition of PD-1 inhibitors or PD-L1 inhibitors to chemo looks better. We've seen in lung cancer that PAT-CR translates into an overall and a EFS benefit, but I'm worried will we see it in gastric. We didn't see it in the first study I showed you with pembrolizumab. So the million-dollar question we should all think about is PAT-CR a good surrogate of long-term response in gastric cancer? I'm not sure we know the answer yet. I think we'll have to see the data. And then finally, this is another exact same. We're just switching up the PD-1 backbone or PD-L1. So here you'll see this is atezolizumab. This is called the Dante trial. It was originally a phase 2 and then got expanded into a phase 3. Again, the chemo backbone is FLOT. I won't labor the point, but you can see the entry criteria there. They're looking at GE junction and stomach and MSI high status. But basically, FLOT plus atezolizumab for 4 cycles. So again, we're looking at different scheduling before surgery and then 4 afterwards, and then maintenance atezolizumab versus FLOT on its own. We haven't seen, again, huge amounts of data, but here's some of the pathologic response rates. If you look at those patients that are, I think PTO N0 would be, a complete response. You're seeing it's 23 versus 14. So the last study I showed you, there was about a 12% delta. Here it's just a little bit under that. But so we're seeing similar kind of data across the board in terms of PAT-CR rate. There's definitely downregulation. I think the lymph nodes are also being improved. If you look at the PT3, PT4, you're also seeing a difference. So basically, on the right, you've got the pathologic regression. As I said, it looks better as we go up in CPS. I don't think that's a major surprise. And then MSI high was a small number of patients. It was only 23 patients here, but we're really waiting on long-term data. In the last 3 minutes, I just wanted to show you a paper that I just published in Nature Medicine, because I think we've got to move beyond this question of FLOT versus cross. I mean, I don't think any other tumor types really fixate on chemo or chemoradiation. You know, they're really moving beyond that. I think we need to catch up with some of the other solid tumors. And this was an effort to do that. Could we look at circulating tumor DNA to predict if we were getting a response in the neoadjuvant window? Because we had all probably thought that we're treating everyone the exact same. You get 4 cycles of FLOT and you get surgery and you get 4 afterwards. But who's benefiting? Is everyone benefiting at the same, or are people not benefiting? So here what we decided to do is, this is a chemoradiation study. We looked at nivolumab. If you look at arm A up the top in the dark blue, these were stage 2 or 3 esophageal GE junction cancers. We gave 2 cycles of nivolumab over a month, or we gave nivolumab plus the LAG-3 inhibitor, relatlimab, on their own. And I was never aware of data in the neoadjuvant setting where we give these drugs on their own. And then we went into chemoradiation with concurrent ICI. So in total, patients got 5 doses of nivolumab or Nivo-Rela, 2 on their own, and then 3 with chemoradiation and then surgery. But the more exciting thing was the serial liquid biopsies to see if we could track ctDNA. Could we see who's responding before surgery? So here are just some representative samples. Up on the top left, this is a patient you could see on day 14, we've cleared their ctDNA tumor variants. That was after 1 dose of nivolumab. So the question is, has that patient who had a CPS of 35, they never recurred for 5 years later? They had a PAT-CR. They had no evidence of recurrence. Could that patient be spared surgery? We've never thought like that. We've always given everyone all the treatment, and then so the million-dollar question is, are we over-treating some patients? On the top right, you'll see a patient with a CPS of 5. Here, they didn't clear ctDNA immediately, but they did clear it just before the pre-op surgery. So that patient also did very well. But in the interest of time, if you look at the bottom right, you'll see in the green, this is a patient whose ctDNA is increasing, and that patient had recurrence-free survival in a few months. So what we saw in our study is those patients that are MRD negative, which is, you know, the post-op session, we've seen this now in multiple different tumors, we didn't have a median disease-free or recurrence-free survival. In those that were ctDNA positive, and this is despite chemoradiation, surgery, and immunotherapy, the recurrence-free survival was 7.8 months. So that's really disappointing, but that's the reality of what we're going to be facing using these particular. I prefer to know if the patients are going to be very high risk. And then on the right, you'll just see patients who are immediately ctDNA cleared do a great thing. What I will say is PAT-CR, I said at the outset, I don't think we can really reliably use it. But what we showed was if you had a PAT-CR, but you were ctDNA positive, the ctDNA results totally made it in the wrong direction. If you had a PAT-CR and you're ctDNA negative, then you're really in a good shape. So we're back to our case, Dr. Shah. I think you want to walk us through this?
Yeah, exactly. So terrific. Thank you so much. So much exciting data and more to come. So we have this, our patients, Catherine, 65 years old with dysphagia, a GE junction, stage 3 cancer, and she elects to incorporate immunotherapy options in combination with surgery. So Dr. Muller, how would you proceed with this GE junction locally advanced patient, assuming that you're not from Germany?
Yes, I mean, for us in Europe, it's very important to assume whether the patients have a lot of lymph nodes or not. And in addition, we have to think about the surgeons, whether they operate with a resection of the esophagus and use the stomach as
as a pull-up,
for the anastomosis, or whether we the surgeons operate from the stomach and go up and resect from the stomach only, from the abdomen only. I think this is a very important question, and therefore CVID classified the junction cancers in CVID 1, 2, and 3. And the classical CVID 1 and 2, which are the distal esophageal cancers, we usually still irradiate. And the classical gastric or CVID 3, which are the subcardial cancers, we always treat with chemotherapy like FLOT alone. I think this could be quite in agreement with you, Ronan. I think the story here is really chemoradiation is very good for patients with locally advanced disease. The FLOT chemotherapy has a stronger impact on systemic disease, and therefore this would be our decision in the Interdisciplinary Tumor Conference.
Yeah, no, that's terrific. So Dr. Kelly, just talking about the ACPE study and actually Dr. Goodman's discussion, she made the point that with the cross regimen, you're really not getting much systemic therapy, and she brought up the PET-directed CLGB study where you actually get both. What were your thoughts on that?
Well, yeah, I thought she made a great point, but and I think the ACPE study was designed before Checkmate 577 came out.
Right.
So they were looking at the older regimen. There was no major surprises for me because we were really worried about low-dose chemo. And I think what you saw in the ACPE study today was if your patient is fit and they're lymph node positive, I think you should be giving them systemic doses of treatment. I don't think we should be messing around with small, low doses of radiation sensitizing chemo,
right,
because I think that was quite clear to me. But what wasn't overly clear was that it didn't seem to have a great effect in those small tumors. So the FLOT, maybe you're over-treating them with FLOT. If you looked at the hazard ratio on the subgroups,
right,
there really wasn't a great benefit for T1s or N0s. So I'm kind of left going, well, I'm thinking based on this, if you have a young patient with lymph node positive disease, I think systemic doses are needed. But if it's an older patient, and most of these are older, with not a huge, big, bulky tumor, then maybe you could still do chemoradiation, but then adjuvant nivolumab. They didn't compare it to adjuvant nivolumab.
Right, exactly. And that's an important point. I mean, I think, clearly the event-free survival is double, like remarkably double. So we're waiting on the overall survival benefit, but it is quite compelling that if you do chemo-RT and if you have residual disease, then, maybe the combination of chemo-RT plus surgery plus adjuvant nivolumab, you could imagine could be better than FLOT. And I guess, just from the ACPE study, the other thing that we were talking about earlier was that, the delivery of the cross regimen, the chemo-RT, it was like 67% or something like that. And, it wasn't broken down. We need more information. They did say that 98% of the patients did get the full amount of radiation. So it could be that maybe they missed one dose of chemo, who knows? And one thing that may have been actually more informative is the percent of the dose, the planned dose given. If it was 80% or higher, typically that's pretty close to full dose, and that wasn't described.
And one thing that I also say is, and I thought it was a great study, but the chemo RADS group totally underperformed, like you're saying.
Right.
We've never seen as poor data as we've seen with this, so it's just hard to understand what was happening with those patients that were getting chemoradiation.
And even more, we do have also the NEO-AEGIS trial, which has been also European trial comparing cross versus neoadjuvant chemotherapy, unfortunately only with 20% FLOT, but rather with cisplatin 5-FU, and it also showed that the response and overall survival is more or less similar.
Yeah.
I think the story here is really we should focus in the future on the combination of chemotherapy and IO, as you mentioned the Matterhorn trial, and I'm sure that there is music in it and that we will see a clear benefit. And on the other hand, if we choose the chemoradiation, particularly the patients with a bad prognosis and not complete regression, then go for 577's protocol and treat the patients with the with adjuvant nivolumab.
And then just one last comment on the ctDNA. That's incredible data that you have there. And in other studies as well as this one, which was done prospectively, a positive ctDNA portends a really poor outcome. And there are plans, both in Europe and also through the cooperative groups, of actually using ctDNA potentially to, not only as a prognostic, but potentially to help drive some treatment. We don't know if, changing therapy, if you're ctDNA positive, would make a difference, or doing more treatment earlier would make a difference. These are questions that your study opens up, I think.
I'm a big believer in this. I think we've come across, now obviously the sensitivity of the assays, those of you that are at AACR, there's lots of companies in this space. But I'm a big believer in this. We've seen the same thing time and time again. What I'm really looking for, though, is from these phase 3 trials, when they show us their plasma data, their biomarker data, hopefully, because all the studies we've seen today, my study was small. We saw a number of posters yesterday. They're all small. But we really need to see that randomized phase 3. I know they've collected plasma all the way through. I'm really excited to see when they show us the ctDNA, because there's definitely some people that are responding. Can we find them? And then the trial's not negative. If we can show these people are responding, that's the way we should be looking at it.
Right, exactly.
But it's still a question to you. At least for us, we don't have approvals for ctDNA, and still it's not reimbursed. I don't know whether this is the case for US. I think we still have to be careful, even if it is a clear signal that for minimal residual disease. But so far, I think we still should treat the patients according to the standards.
Unless you have a trial, exactly right.
Yeah,
exactly right.
Yeah, I want to make sure it's not standard. This was on a study.
Yeah.
But people are doing it in colorectal cancer now, but it's not standard in esophageal gastro.
Right.
Yeah.
Perfect. So the last part, we'll talk about the current landscape and future directions of targeted therapies, moving away from immunotherapy for a minute. So we have a 70-year-old person diagnosed with stage 4 gastric cancer, metastatic to the lungs. And how would you approach the molecular profiling? What should our patient be tested for? Claudin, EBV, HER2. Let's talk about it. So this is the landscape of biomarkers in upper GI cancers. And, I first saw this kind of a pie chart for lung cancer, and I was so envious. I mean, they had EGFR, they had ALK, it was amazing. We have the same thing now. So, we have Claudin 18.2, we have PD-L1, MSI high, HER2, FGFR. These are all, I'm mentioning the ones that actually have therapeutic options that either are positive or, we're waiting on data for a target. So HER2 is positive in 15 to 20% of patients. Every patient needs to be tested for HER2 because it changes your treatment. MSI high, very, very sensitive to checkpoint inhibition, 3 to 5% of patients, not insignificant. Everybody needs to be tested for that. And PD-L1 helps you refine your use of immunotherapy, as we'll talk about. Hopefully later this year, we're going to get approval for zolbetuximab. Claudin 18.2 is positive in 30 to 35% of patients. That could change your management. In particular, and we'll see the data, it seems to be enriched in tumors that are CPS low. So it's that unmet need that is really quite important. And then FGFR2b, either overexpression or amplification is associated in 10 to 15% of patients. And we have really exciting phase 2 data, and we have the phase 3 studies that are, I think, pretty much enrolled or maybe completed, and we should have the data for that soon. So let's talk about HER2 positive disease. Who should be tested for HER2 overexpression, and when should we do it? So, this is a table of who, and as you can see across the board, ESMO, Japan, ASCO, and NCCN guidelines, everybody with gastric GEJ junction cancers should be tested for HER2 expression. ASCO, ESMO, and NCCN also recommend at diagnosis. As soon as you have the patient diagnosed, send it off for HER2 because you're going to need it. And, HER2 is really exciting. It's a validated target. From the early days with trastuzumab and breast cancer, we know that overexpression activates a pathway, and this pathway is very favorable for tumor growth, proliferation, anti-apoptosis. If you block the pathway, you have benefits, and trastuzumab, in addition, can activate ADCC. And that's led to a plethora of novel agents. Pertuzumab binds to a different moiety on the HER2 molecule. HER2 is unique because it doesn't have a unique ligand. It actually can partner with HER1, HER3, or HER4 and activate downstream signaling. You also have margetuximab, which is FC modified to increase ADCC. You have trastuzumab emtansine. This is TDM1. This is actually approved in breast cancer. This is a drug antibody conjugate. So you actually use trastuzumab as which carries a payload, almost like a Trojan horse, that it can deliver cytotoxic therapy to the cells. And you have also trastuzumab deruxtecan, which is a different payload, and we'll see is active in gastric cancer. And then zanidatamab, which is a bispecific with a longer arm that actually is optimized to bind to both the second and the fourth motif, and leads to both increased immune activation and also greater inhibition of the HER2 signaling pathway. And then you have intracellular small molecules. So lapatinib has been tested in gastric cancer, was negative, but neratinib, tucatinib, very active. So these are really, it's really quite a lot of options for us. Here's the TOGA study, and just very briefly, if you're HER2 positive, you benefit from adding trastuzumab to chemotherapy. But after the study was done, a post hoc analysis really focused on the HER2 true positive patients, so either IHC3+ or 2+ and FISH positive, and you can see a really significant 35% improvement in survival, median survival of 16 months. So that's the current standard up until KEYNOTE-811, which was in HER2 high, chemotherapy plus trastuzumab with or without pembrolizumab. And this was actually an investigator-initiated trial at Sloan Kettering led by Dr. Janjigian that led to this phase 3 study. And remarkably, it showed an improvement in survival, particularly and specifically in CPS 1 or greater. And that's shown here, the hazard ratio 0.7. And if you're a CPS less than 1, it suggested that there actually may be harm with adding pembrolizumab. So currently, the standard is for HER2 positive, CPS 1 or greater, you would use trastuzumab, pembrolizumab, and chemotherapy. And with that, you can get survivals, which are really quite remarkable here. In this case, at 2 years, you're getting a 30% survival. It's really quite impressive. And then this is, that was PFS. This is the OS, and you can see just what I was saying earlier. This is all patients, hazard ratio 0.84, but when in the CPS 0.8, 1 or greater, you have a hazard ratio of 0.8, and this was positive here. And then this is the response rate. So irrespective of CPS status, you're having a really tremendous response, about a 75% response. And you can see that it's actually, the response rate is higher, but also the number of clinical CRs is higher, and the depth of response is higher. So based on this higher response rate, the FDA did grant approval of pembrolizumab, but now it's really, the approval is limited to CPS 1 or higher. Trastuzumab deruxtecan is a drug antibody conjugate. So this is a unique, and there was a session at ASCO about that. This is a really new class of drugs. It basically uses the antibody to target the cells, and then it delivers a payload. The payload are here, these small molecules, which are actually drugs. And often they're drugs that would be too toxic if given intravenously. So this is a way to deliver specifically to the tumor bed, the tumor location, these cytotoxic drugs. And here it's delivering deruxtecan, which is a topo-1 inhibitor. And you're going to learn some new terms here. So there's something called DAR, D-A-R. So that's the drug-antibody ratio. It's the number of the drug molecules that are on the antibody. So here for trastuzumab deruxtecan, the average DAR is about 8. It's really quite high. You're delivering 8 molecules of drug, chemotherapy drug, with every antibody that binds to the surface of the cell. The other drug that was tested, the other ADC that was tested was trastuzumab emtansine. That had a DAR of only 2. You're only delivering 2 drugs for every antibody that's given. And then the other thing that's important here is whether or not the antibody, payload, the drug, can be cleaved off, so it can be delivered to the cell, but also to the surrounding cells. And that's true in trastuzumab deruxtecan, or is it covalently bound and not cleaved? And that actually has implications as well. So there's now a whole new chemistry and biology on how to create these drugs in a better way. So TDXT, trastuzumab deruxtecan, was first shown in the Destiny Gastric 01 study done in Japan and Korea. It had a remarkable about 40% response rate and an improvement in survival. And then the Gastric 02 study was a follow-on study done more in the West, which largely recapitulated those results. In terms of toxicity, generally it is pretty well tolerated, but it is more toxic than trastuzumab. You are delivering chemotherapy, so you do see neutropenia, 50% with TDXT. You do see a drop in the platelets, leukopenia, but the thing that's most concerning is interstitial lung disease. And interstitial lung disease is a toxicity that actually led to some grade 5 events, some early deaths when they were first looking at TDXT. But early identification of this toxicity can be managed. We're going to get to that in a minute. So Gastric 01 and Gastric 02, the Destiny studies, led to approval of TDXT. It's approved in the United States and in Europe in the second line or later, after prior trastuzumab-based therapy, and in Japan it's approved in the third line or later. So this is an exciting area. So we now have, beyond trastuzumab, we have trastuzumab deruxtecan as an approval in HER2-positive gastric cancer. And here's the slide on interstitial lung disease. So you have a patient who's on trastuzumab deruxtecan. If they have like a small cough, don't blow it off. You have to think about maybe they have early signs of pneumonitis. Get a CAT scan. If you have stranding, fine ground glass stranding, you should address it right away. Start with steroids. You may consider a pulmonary consult and a bronchoscopy. You hold the treatment. You make sure that it goes down to less than grade 1 before re-challenging. If it's significant, you can't re-challenge. That's a really key thing for ILD with trastuzumab deruxtecan. So there's been an evolution of targeting HER2 in upper GI cancers. Just 12 years ago with the TOGA study, we had trastuzumab. And then in the last 2 years, we now have trastuzumab and pembrolizumab for HER2-positive CPS greater than 1. And in the salvage setting, second line or beyond, trastuzumab deruxtecan. There is a black box warning, or not warning, recommendation that you should recheck the HER2 status in patients after progression on trastuzumab. And the reason why is because about 20% of the time, you're going to lose the HER2 expression in patients who've been on trastuzumab. So this is all very different than breast cancer. We used to think that once we got these targets, we could have like a HER2 clinic or an EGFR clinic, but the disease context matters. We have data in gastric cancer that you don't continue trastuzumab beyond progression. That's what you do in breast cancer. But in gastric cancer, there was a Japanese study that had progression on first-line trastuzumab. Patients were randomized to receive either paclitaxel or paclitaxel with trastuzumab, and there was no improvement in survival. Continuing trastuzumab beyond progression doesn't help. That's because of resistance mechanisms, and truly, HER2 is a subclonal event in gastric cancer, not a clonal event as it is in breast cancer. But it's quite active. Trastuzumab deruxtecan got regulatory approval, 40% response rate, improvement in survival, and that's led to a plethora of new drugs that are being developed and evaluated. Zanidatamab is a bispecific antibody. We're very excited about the Gastric GEJ study that should be available in the next year or so. We have iverpopcept, which is an anti-CD4 antibody. That's the ASPEN-06 study. And then we have other ADCs as well. So let's talk about other targets. Claudin 18.2. This is a relatively new kid on the block. I mentioned at the very first slide, Claudin 18.2 is a protein that's in the gap junctions of cells. The process of malignant transformation, actually cells lose their polarity. The way they lose their polarity is that the gap junction gets broken, and that way it gets the cell proteins that are in the gap junction becomes exposed. Claudin 18.2 becomes exposed, and it then becomes a target, a novel target. Zolbetuximab binds the Claudin 18.2, and it activates ADCC, and that's the mechanism of action. And here we can, here's some important clinical pathologic features of Claudin 18.2 expression. So it really seems to be a minority of patients who are positive are also CPS 5 or higher, only 17%. So it may actually really be that unmet need where you have your CPS is less than 5, immunotherapy may not work as well, and if you're Claudin 18.2 positive, you might have a new option. We'll go through the data for that. The GLOW studies and the SPOTLIGHT studies were positive. Over 1,000 patients were treated, and that's with zolbetuximab. This is a monoclonal antibody that's humanized and engineered, and it, we'll go through the data, but it really does improve survival when combined with chemotherapy for Claudin 18.2 positive patients. There are a whole host of other novel therapies that are being developed targeting Claudin 18.2. There's the CAR T program, LY011 or CT041. There are different ones that there's some preliminary data already. You're able to activate tumor cell kill by this CAR T program. You have BiTEs or bispecific antibodies that combine CD3 plus a Claudin target, for example. And you have ADCs, which are what we just talked about them, delivering a payload to Claudin 18.2 positives. All of these are in clinical trials, and the initial data are really quite impressive. So here are the two phase 3 studies of zolbetuximab with chemotherapy. The SPOTLIGHT study examined FOLFOX with zolbetuximab versus FOLFOX with placebo, and you can see that the addition of zolbetuximab did improve overall survival, the hazard ratio of 0.75, and you have a 18-month overall survival with zolbetuximab over here. The GLOW study used CAPOX and also improved survival. That's the top curve here. The hazard ratio of 0.77. So two independent studies together, they have a hazard ratio of 0.75, 0.77, really quite consistent. And in terms of the update from SPOTLIGHT at ASCO this year, we have the final overall survival results, a median of 18.2 months versus 15 months. The hazard ratio is maintained. So it's really quite exciting. And in table form, you can see the delta, the improvement in survival is very similar. About 2.7 months here, 2.2 months here. Hazard ratio, very, very similar. The improvement in PFS, also very similar. Hazard ratio, about 0.7. The main toxicity with zolbetuximab is nausea and vomiting. And you might expect that to be an on-target effect, because remember, this gap junction protein is expressed in the upper GI tract. Targeting that might give you a lot of nausea, and that's what we saw with zolbetuximab. If you can manage this nausea in cycle 1 and cycle 2, it tends to go away. So that's a key aspect of using zolbetuximab in this population. And then finally, I'm going to talk about FGFR2 in gastric cancer. So FGFR2, similar to HER2, is a growth factor signaling cascade, and it leads to pro-proliferation, pro-survival, anti-apoptosis. And bemarituzumab was this is futibatinib, and there's infigratinib. These are approved in cholangiocarcinoma, but in gastric cancer, we have data also with bemarituzumab with the FIGHT study, and the phase 2 study was really quite exciting. And if you even enrich further by not just 5% of tumor cells, but 10% of tumor cells, you have even a more significant separation of the curves. There's really quite a lot of data in solid tumors across the board. If you have a target and you choose a drug that hits that target, your survival is going to be better. And that's really what we're seeing in gastric and GE junction cancers as well. And then finally, this is a really novel target, DKK1. So DKK1 induces an immunosuppressive tumor microenvironment. It's a protein that's activated by beta-catenin signaling, which is a key signaling, key protein in gastric cancer. Beta-catenin is activated by H. pylori, and so DKK1 is actually transcribed and then expressed, and that leads to activation of the oncogenic non-canonical Wnt pathway and leads to tumor growth and metastases, as well as an immunosuppressive microenvironment. And the LEAP Distinguished study is a study looking at DKN, which is inhibitor of DKK1, and this was presented at a previous ASCO by Sam Klempner in 2023, and it was really quite exciting in terms of the initial activity that was shown here. So the median PFS was 11 months, the OS was 19 months. That was really quite remarkable, and it was maintained whether you're CPS low or high. And the overall response rate was 73%. And so this is a small study, but it's really quite exciting data, and that's leading to a phase 3 study. So we're looking forward to that as well. And then just to comment on other pathways or other biomarkers. So MET is amplified in gastric cancer, and it was actually, and so is EGFR. And these are a series of large phase 3 studies that were examining targets of EGFR and MET. And all of them were unfortunately negative. But what's shown here in this, kind of this plot is that the potentially there is an issue of patient selection. And again, it gets to the idea that if you have a target and you're hitting the target, you might have benefit. So here at the bottom, if you have high expression of EGFR, you might actually have benefit of targeting EGFR. That was shown in a study subsequently. So that was a whirlwind tour. We talked about immunotherapy in the metastatic setting. We talked about immunotherapy in the localized setting. And then we just talked about all these new targets that are coming down the pike. HER2, Claudin 18.2, and FGFR. So we have our patient, Jonathan, metastatic gastric cancer. His profile, HER2 negative, Claudin positive. How would you approach this treatment, this patient for treatment? So maybe Marcus, do you want to start, since actually zolbetuximab was developed not far from you?
Yes, zolbetuximab was developed in our university clinic together with the company BioNTech, which is also famous for the vaccine. And the story, as you very nicely presented, is that Claudin targeting is inducing nausea and vomiting, and this is quite severe. And patients have to be treated well, that they can cover, that they can cope with zolbetuximab. And my first question is, of course, if the patient is Claudin positive, and we saw that already in some questions we answered already. So the question is the patient also CPS positive? We know that the responses is more or less very similar for Claudin positive ones versus CPS5 positive ones, and therefore immunotherapy is more easy to be given. However, we do see quite only 20% in all the trials with zolbetuximab have been positive for Claudin. So I would think that the zolbetuximab drug is an effective drug, of course, particularly in CPS negative patients or CPS lower than 5. Otherwise, I would treat according to the overall condition of the patient.
Thank you very much. No, that's very good. And then we're going to have some time for questions and answers. And while this is up here, I think I wanted to ask a question that was from the audience. Let's see. This is an important question for all of us, I think. I'll start with Ronan, you. Do you treat esophageal GE junction and gastric adenocarcinoma all the same? And let's start with the metastatic setting.
Yeah, I mean, the answer is probably yes, but let me just talk about so we know HER2 is higher expressed at GE junction and esophageal than it is gastric. So you may see more HER2 positivity in those esophageal patients, which would allow you to use the Keynote 811 regimen now, which was pembro, trastuzumab, and chemotherapy. So if you know, I don't know if we've seen big differences in Claudin expression yet across anatomical locations, but we've seen that with, I think it's higher in the diffuse histology, whereas HER2 is higher in the intestinal histology.
Right.
So we're beginning to tease it out a little bit.
Right. Yeah, I think that if you're expressing the biomarker, it doesn't matter where you're from, right? Like if you're MSI high, it doesn't matter if you're esophagus or GE junction or adenocarcinoma. Marcus, this is a question for you. So in Checkmate 649, there was an early separation of the curves. But with the tislelizumab data, it seemed like the separation of curves were later. Do you have a sense of why that might be?
I think the question is really whether you have measurable or only evaluable disease. This is the first question, and I think the tislelizumab study was particularly done in Asia. And I would rather think that patients with peritoneal carcinomatosis, which may be more common in China than since we have more upper GI cancers here in the US or in Europe, this might have a role, might play a role that the stabilization of disease, particularly in patients with peritoneal carcinomatosis, may induce the overlap of the curves. But at the end, the immunotherapy will act strongly, particularly after 6 or 8 months.
That's very interesting.
Yes.
Sorry, just coming back to the Claudin and the Spotlight and Glow. I thought there was a difference between the GEJ and the gastric cancer because there was less benefit for the Claudin 18.2 positive GEJ tumors. So maybe there is a difference, between location of tumor and the biomarker.
Yeah, that's a great question. So Yeah, so there's the guy that read the fine print. No, I'm joking. The GE junction was a small portion of the whole population, but you're right. In both Spotlight and Glow, it seemed like the GE junction maybe benefited less. It's actually quite curious. I think even if you look at immunotherapy in Checkmate 649, the GEJ seemed to benefit less. The hazard ratio is a little bit closer to 1. But that's not true for example, HER2, where it seems like that, it seems to benefit more. I think that the biomarker is just part of the story. There are other factors that are playing a role here that may impact the benefit of the target that we have, and we just don't understand the GEJ that well.
Yeah, we've seen that before, even with FLOT. If you looked at the FLOT4 data, the GE junction didn't do as well as the gastric. And then in 577, which was an early stage study, GE junction did less well than esophageal adenocarcinoma. So a lot of us have speculated, is the immune microenvironment different? We know that there could be some epigenetic changes at the GE junction. I just don't think we have a good answer yet.
But still, I mean, the tumor genome atlas will guide us in the future even more, particularly for FGFR2b. I mean, you very nicely showed the Fortitude trials. I would like to highlight that this will be an excellent opportunity in the future, particularly in combination again with IO.
Thank you. Thank you for your question. Yes.
I just wanted to find out, is capecitabine oxaliplatin interchangeable with FOLFOX if there is no problem swallowing or absorption? Are they interchangeable,
So that's a great question. So you're right. So a lot of patients with upper GI cancers can't tolerate pills. And for those patients, I think, FOLFOX might be preferred. But it's interesting. So in countries where there is screening, most patients with advanced gastric cancer are diagnosed after resection of their primary. And there, the swallowing isn't an issue. So S1 is standard in Japan. That's an oral tablet. Capecitabine is very active in Korea as well. So that explains partly why the company want to do 2 studies, because in North America and in Europe, FOLFOX is really the preferred because a lot of people do have dysphagia. But in Asia, Japan, Korea, even parts of China, an oral 5-FU moiety is preferred because then you don't need the Metaport, it's less complicated, things like that. I think where it could be studied, there's no difference in activity between FOLFOX and CAPOX. There are differences in toxicity profiles and things like that, but when you're comparing them, there's no difference in outcomes.
I might add that S1 has been tested in the FLAX trial.
Yes.
And S1 is inducing less hand-foot syndrome, and I think it has also no cardiotoxicity in that regard. Personally, I like the SOX regimen, which has been used in Asia quite a bit.
Is S1 approved in Europe?
Yes.
I don't think it's approved in the United States.
Is it not?
No.
Oh.
Yeah. Terrific. Any other questions? Let's see, we'll have one over here. All right, so here's a question. In a patient is HER2 negative, PD-L1 positive, MMR proficient, that does not have a good response to neoadjuvant FLOT. So this happens all the time, and we've talked about this. Patient who's HER2 negative, MMR proficient, and receive neoadjuvant FLOT, and there was a poor treatment response. The path is T4 and 3. Do you continue FLOT afterwards, or what do you do next?
It's really difficult, right, if they haven't responded to chemo. And this is where I prefer to use the ctDNA. That's what I was going to say. But I think that's really where we're going to go, because it's going to guide us in terms of trying to personalize our treatment options for patients. Up to this point, we've just been, I guess, blindly giving, 4 cycles and 4 cycles and hoping it's going to work. I just prefer if we had a more nuanced approach than that.
Right.
But and then I guess if this becomes main, our prime time where we're doing this all the time, then the docs will have a decision to make about do they switch to an alternative therapeutic approach.
Right.
Because that's really what we have to do. I would not give more FLOT if the patient's continuing to progress on FLOT. You have to think outside the box. I think that's what we're going to get to.
I mean, I think, your study wasn't exactly this way, but if you give FLOT, you have surgery, and you're still ctDNA positive, what confidence do you have that more FLOT's going to clear it?
No, zero. I mean, not zero, but, very little.
Very little.
But then what do we do?
Right.
We know in colorectal that if you throw a lot of things, like can you go to a FOLFIRINOX approach? I mean, who knows? We don't know the answer, I don't think. So that patient's just in trouble. And, I think we're going to have to think about novel trial designs to see, maybe there's an ADC approach that's on the horizon. But
Right.
I think that's where we're going to have to be, smart about it.
At least in Germany, I am responsible for the guidelines, and so far we do not have any recommendation for adjuvant chemoradiation, particularly after neoadjuvant therapies. And I think in such a patient who has more or less a bad prognosis, I think we should be careful with over-treating and keep the drugs we have or irradiation we have for progressive disease. I think quality of life in such a case is very important, and I would be careful not to overdo it only because of a few lymph nodes. I mean, I would rather say if the patient has really clearly a measurable disease, then go hard and treat them with escalation of the treatment.
Right, and of course we had the critic study, which asked that question that was negative. So I'd like to thank everybody for all their questions and for paying attention. Thank you very much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit at peerview.com/VTE860. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, Hope for Stomach Cancer. This activity is supported through educational grants from Astellas, Beijing, and Bristol Myers Squibb.